star speaker of the day, Zach Hickman. It's my pleasure to introduce a longstanding friend and co-resident. He went to Columbia Medical School and residency, and then afterwards did a fellowship in neurotrauma and critical care. And those of you who have worked with him know that he's very passionate about the details of patient management surrounding neurotrauma. And now we'll be talking to us about TBI in the elderly. So thanks very much, Zach. And here you go for the screen share.
Thank you, Dr. Kellner. Let me just share my screen here. Everybody can hear me okay? See my slides? Okay. So I thought we'd talk about traumatic brain injury in the elderly. We just had a trauma symposium at Elmhurst a couple of weeks ago that was all on trauma in the elderly. This is obviously a growing concern in the aging population. I have no financial disclosures. This is just a brief agenda, so it'll be a little bit of a whirlwind tour. We'll go over some epidemiology and then outcomes, specifically in elderly TBI. We'll talk a little bit about frailty, and then about the management and treatment, in particular anticoagulation and antiplatelet medications, which is a huge concern in this patient group. And then I'll touch a little bit on subacute and chronic subdural hematomas. We obviously had a great lecture by Dr. Adam Arthur in the Holland lecture a couple of weeks ago, so I won't belabor the point, but I'll touch on a couple of points and reiterate and emphasize a couple of points that he had made. So in terms of the epidemiology and burden of TBI in the elderly, if we look at just TBI in general, at all age groups, traumatic brain injury is globally the most common neurological disease. It even is more common than stroke and Alzheimer's disease. I guess if you lumped all degenerative diseases together, it'd probably be higher than traumatic brain injury. But in the United States, there's over 250,000 TBI-related hospitalizations every year, and almost 100,000, getting close to 100,000 TBI-related deaths. That translates to over 500 TBI-related hospitalizations and almost 200 deaths per day in the United States. If you look at, for instance, glioblastoma, there's 13,000 glioblastoma diagnoses every year and about 10,000 GBM deaths. So it's several multitudes higher than that. If you look at overall yearly costs, this is a little bit older data, but in the United States, it's over $75 billion yearly in the United States. TBI is the resulting cause of death in 1/3 of all trauma cases, and the most common cause of TBI in the United States and in higher income countries is falls. So reason why we're talking about this is actually over the last few decades, there's been a shift in the demographics of traumatic brain injury. It used to be considered a disease predominantly of younger patients, particularly adolescents and in the 20s with motor vehicle accidents and kind of high risk activities, but is now predominantly a disease of older people. There's been an increasing incidence and prevalence of TBI, as well as the population has aged, a higher incidence of TBI in general in this age group. Basically, age 65 or older rate is about 15% of the United States population. It's probably a little bit higher now, but accounts for almost half of TBI-related hospitalizations and over 1/3 of TBI-related deaths. Again, the most common etiology is fall. If you look at the incidence of acute, subacute, and chronic subdural hematomas, nowadays, most patients with acute subdural hematoma are actually in the elderly population. And in some studies, over 50% of patients admitted for acute subdural hematoma are actually over the age of 80. As Dr. Arthur had mentioned, by 2030, chronic subdural hematomas stand to become the most common disease that we treat surgically. If you look at center TBI, which is a large European-based study, kind of the European corollary to the track TBI that we have in the United States and Canada, the median TBI age is now 50 years old, and over 1/4 of patients are over 65 years old. And 20% of those patients, 20% of patients are on anticoagulation or antiplatelet medication of some form. So this is just some graphical representations of that. The red line here on the left is patients that are aged 65 or older. The blue line is those that are under 65. And so you can see that the geriatric population basically is equivalent to the patient age, to the number of patients that are under 65 years of old. And then you can see in terms of hospital discharges and deaths, there's definitely an upswing in the age group that's over 65, as we would expect. So there's an increasing mean age of TBI patients over time, and this has been shown in the study from UCSD, where they looked at 3,000 TBI patients that were admitted to their institution over about a 7-year period, and there was basically an increase of roughly 4.4 years over that time frame in the mean age of their TBI patients. And why is this important? Well, we know that age greater than 65 is a higher risk for unfavorable outcomes, and in this study, those patients had a 4-fold risk for unfavorable outcomes compared to the kind of quote unquote traditional age of TBI that we would expect, which was, in patients in their 20s and early 30s. Again, most common mechanism are falls in this group. As I mentioned as well, there's an increasing incidence of acute subdural hematomas, particularly in patients that are older and older the age of 80. So why is this important? As I mentioned, there are some specific factors and risk factors in these patient groups that influence outcomes. Firstly, as we all know, that age is one of the important outcomes in how patients do after TBI in general. And if you look at the elderly population, the overall in-hospital mortality in patients with elderly TBI is about 16%. The vast majority of this mortality, though, is in patients that have moderate and severe TBI, as would be expected, and mild TBI is still around about 5%. As we know, there's increased mortality with age, and this just graphically represents that. But if you look at patients that are 70 and 80 years old, they were 12 to 21 more times likely to die after a severe TBI than younger counterparts, as well as having increased ICU length of stay and hospital length of stay. So there's certain specific risk factors besides age. Some include a need for neurosurgical intervention, pneumonia, and cumulative comorbidities. It should be noted that even in patients with mild TBI, being elderly is a strong predictor of mortality and unfavorable outcome. But it's all not doom and gloom. There are some patients, particularly almost a quarter of comatose patients, and more than half of non-comatose patients that can have a favorable outcome at long-term follow-up, and we'll go into that a little bit more detail. The risk factors for mortality in elderly TBI, if you look at these ones that are highlighted in red, those are kind of like the traditional main risk factors for mortality in all TBI patients. And then if you look at the ones that I highlight in yellow, these are ones that are often more common in elderly patients and drive outcome in this patient group a lot as well, besides age. And that is the kind of cumulative burden of comorbid conditions that they may have, as well as antithrombotic therapy. And if you look at antithrombotic therapy in general, it's really anticoagulants, in particular warfarin and DOACs, that are risk factors for mortality. There's less evidence that clopidogrel or aspirin monotherapy. There is some evidence that dual antiplatelet therapy is a predictor, at least, of hemorrhage expansion in these patients, but less evidence that it influences mortality. And we'll get into a little bit on that more detail later. Survivors, as I mentioned, can have good functional recovery, and that's particularly in patients with mild TBI, as can be expected. There are poor outcomes in patients that have moderate or severe TBI, but by 6 months, there's a large proportion of older patients that can have a good functional recovery, again, mostly in the mild TBI group. And this is just graphically representing. You can see as follow-up time goes out, the patients with that have an unfavorable outcome in the mild TBI group tend to decrease as most of those patients recover. But a lot of patients with moderate and severe TBI have persistent poor recovery in the elderly population. So I want to kind of shift gears a little bit and talk about frailty, because we're talking about kind of age as just as a number, but what is really important in the elderly population is really frailty. And it's really important actually in all age groups. Frailty is not a direct consequence of aging. It's really, it is related to age in that it does increase with age, but it's really an age-related decline associated with chronic diseases and conditions. And basically what frailty represents is a physiological kind of threshold at which there's when it reaches a cumulative critical mass, these patients become vulnerable to specific stressors such as a traumatic brain injury and have a less chance of recovery and higher mortality. So it's more common with an aging population. It's more common in women. It's also more common in socioeconomic disadvantaged groups and ethnic minorities. And patients that are frail, and there's multiple different models and different scores you can use to assess frailty, but patients that are frail are more likely to require hospitalization, more likely to have complications, and they have higher rates of mortality and unfavorable outcomes, as well as dependence on long-term care. So frailty results in increased mortality and complications, but there's no real agreement on any single score or index for assessing frailty and TBI. And if you actually look on PubMed, frailty has been kind of like a hot topic, particularly in critical care circles and trauma circles for the last 10 or 15 years. But if you really look at it for TBI, it's really only been in the last 4 or 5 years that you started seeing articles published specifically looking at frailty and TBI. There seems to be a differing impact of frailty in TBI, and particularly in older patients, and that frailty is really more strongly associated with deaths and disability in milder TBI. It's almost as if the impact of the frailty is actually diluted if this TBI is more severe. And there are different things that you can do to kind of counteract the implications of frailty. One is obviously assessing frailty in a patient to know whether or not they're have risk factors for mortality and for complications, prevention of falls, multidisciplinary team-based care, and interventions to prevent and reduce frailty, including optimization of nutritional status, pharmacological interventions, and physical exercise. A lot of those things are obviously taking place before the patient even reaches the hospital. This is just again showing that in an analysis of over 500,000 TBI cases nationwide, patients that were more frail had increased odds of complications, unplanned ICU admissions, unplanned need for operations, increased ventilator, ICU, and total length of stay. And again, this is just reiterating the same thing, that the more frail you are, the more likely you are to do poorly. So in terms of management and treatment, the first thing I would argue is that all elderly TBI with a positive head CT should be treated at trauma centers. It's been shown that the mortality for these patients is significantly reduced if they're transferred to either a level 1 or level 2 trauma center from a lower level trauma center like the level 3 or 4 or from a community center. So our trauma criteria at Elmhurst is to basically transfer all patients that are not at a trauma center to us, but in particular, elderly patients should be considered a high-risk group, and those should be, the evidence would suggest that those patients should be transferred in almost all cases. Additionally, even though I had mentioned that elderly patients, and particularly frail patients, have worse outcomes, there is evidence that elderly TBI patients can do well if they have surgery. So there was a study done by the group from Pittsburgh and they basically looked at patients that were controlled for the severity of their injury as well as their comorbidities. So these were patients that they were basically had an equipoise of whether to do surgery or not, and the decision, they presented both options with the family and the patient. The family chose one or the other, and then they looked at these patients, and basically what they found is that there was basically relatively similar outcomes with a trend towards decreased mortality in the patients that were operated. And then when they adjusted for covariates, actually the patients they operated on died at about half the rate of the ones that were non-surgical. So when we're evaluating whether to do surgery on a patient, yes, we obviously have to keep into consideration whether they can tolerate the surgery and the risks of general anesthesia and surgical intervention. But all things being equal, patients that we operate on tend to do as well, maybe even a little bit better than ones we don't. And so what really is the thing we need to start focusing on, with which there's very little research, is really where that threshold relies, in particular with respect to frailty, in terms of assessing a given TBI patient's frailty and figuring out, are they so frail that a surgery is going to make them worse, or are they going to be able to withstand surgery? And if they can withstand surgery, then if they're an operative candidate, then probably surgery is going to benefit them in that case. Again, this is just another reiteration, another study that indicates that we shouldn't be too nihilistic about surgical intervention in patients with elderly TBI. And when they were looking at risk factors for patients that were 80 years and older, the patients that got operated on tended to do better than those that didn't. The next, I'm going to spend a little bit of time going through anticoagulation and antiplatelet medication, because this is obviously a major concern in these patients. Elderly TBI patients tend to have a high rate, as we can expect, of both pre-injury anticoagulation or antiplatelets. About 20% of these patients are on one or either or both. Warfarin and direct oral anticoagulants, as well as potentially dual antiplatelet therapy, tends to have the highest risk compared to monotherapy with aspirin, which doesn't seem to have as much of a significant risk when it comes to hemorrhage expansion and mortality. So if we look at these patients on the antithrombotic therapy, we see that in general, patients with antithrombotic therapy have higher rates of intracranial hemorrhage after a TBI. They have higher rates of functional dependency and higher mortality. In particular, there's an increased risk of hemorrhage progression on patients that are on warfarin or warfarin plus an antiplatelet. But risk and mortality doesn't seem to be associated as much with antiplatelet monotherapy, but it is associated with dual antiplatelet therapy, warfarin, and DOACs. And just this is a schematic showing that looking at aspirin monotherapy, they're compared to patients that were on no therapy, no anticoagulation or antiplatelet therapy at all. There's basically an equivalent amount of worsening on their second head CT, which is around 20 to 30%. Same amount of mortality. They actually had less need for neurosurgical intervention in those patients. But if you look at patients that are on warfarin and then on also on Plavix, those patients had significantly higher need for neurosurgical intervention and mortality. As I mentioned, dual antiplatelet seems to be, as well as anticoagulation, seems to be associated with more severe TBI. So in general, patients that are on either anticoagulation or dual antiplatelet therapy, when they have a TBI, the TBI is more severe. So the bleeding at the time of injury tends to be worse. There tends to be higher rates of brain herniation. This study from Japan showed that patients with dual antiplatelet therapy also had a higher mortality. That mortality seemed to be driven, though, by the increased severity of the TBI at the moment of impact. And these are just other studies that basically showed that pre-injury dual antiplatelet therapy was associated with increased risk of traumatic ICH expansion. It may, in some studies, be increased, those patients may have needed increased neurosurgical intervention, but not in all studies. But most studies seem to indicate that there was not an increase in mortality or increased hospital length of stay in these studies, and these were all meta-analyses actually. But there's been no randomized control trials looking at this, as well as no randomized control trials looking at reversal of either anticoagulation or antiplatelets in this patient population. In terms of patients that had a negative head CT, so patients that just have a concussion, for instance, and there may be patients that are obviously that we're worried about that are either on dual antiplatelet therapy or on DOACs that had a TBI with an initial negative head CT. One of the questions is, do those patients have increased risk of delayed bleeding? And there is a slightly increased risk of delayed bleeding in patients with dual antiplatelet therapy and direct oral anticoagulants, but it's quite small. It's in the range of 1 to 2%. So in terms of reversing anticoagulation or antiplatelets, the first thing is obviously to discontinue the offending agent, not to continue giving it if they're having active bleeding. And then generally, a decision needs to be made on reversing the anticoagulation. The literature would support that in most cases, patients with supratherapeutic warfarin, as well as probably direct oral anticoagulants and dual antiplatelet therapy, plus or minus Plavix, who are at high risk of hematoma expansion or have an operative TBI should be reversed. Really, the jury's out, though, on patients that have antiplatelet monotherapy, particularly aspirin, which is obviously the most common antiplatelet monotherapy. When to resume anticoagulation and antiplatelet therapy, if it's necessary, is also a controversial topic. And so really what I always educate and teach our residents is that really that decision really needs to be started with a review of the indication for anticoagulation or antiplatelet therapy. We see a lot of patients that come in with a TBI that are on either anticoagulation or antiplatelet therapy that don't necessarily need to be on it. They've just been continued on it for months or even years past when the indication for its initial indication was given. So, these are a list of indications kind of in order of probably severity, but, patients with a traumatic blunt or cerebrovascular injury that occurred from that index TBI do have a short and long-term stroke risk. And so those patients probably are going to need some form of usually antiplatelet therapy, sometimes anticoagulation therapy if it's a venous cerebrovascular injury. Patients with heart valves are obviously going to need to go back on something at some point. If you've had a recent PE or DVT or recent MI, if you have a drug-eluting stent and you're still within that 6 to 12-month window, and then if you've had a stroke or you have an atrial fibrillation, those are patients that you might need to go back on it eventually, but you probably have a longer time window that you can hold the anticoagulation before resuming it. And all these things are really, a risk-benefit discussion with the patient and the family, and with your, in a multidisciplinary teams if you need to get an assessment of what their, non-neurological risk is from complications from holding the anticoagulation or antiplatelet therapy. This was a consensus document that was developed by several societies in Europe, mostly Italian neurosurgical societies, that just looked at what they basically used the Delphi model and looked at different methods of reversal and then different appropriateness of that based upon the bleeding risk as well as the thrombotic risk. And you can see that, really stopping antiplatelets and then giving patients with a platelet transfusion, that was kind of the most uncertain out of all of them. So, they were pretty certain that, if you attaining a low INR, if you were going to consider surgery for a TBI was appropriate in most cases, and then varying degrees of certainty for difference. So this is just to show that it's still a controversial area and there's no definitive answer yet at this moment in time. This is our algorithm at Elmhurst Hospital that we use for reversal of anticoagulation, antiplatelet after trauma. I won't get into the nitty-gritty of this, but we just follow the algorithm. If you're, have, say, for instance, a DOACs, the options are really either PCC or Andexanet or a direct reversal agent, say, so Praxpine in the case of Pradaxa or Andexanet in the case of Apixaban, for instance, which we don't have in H&H, but we follow this algorithm when we want to reverse patients. This is an algorithm from the University of Maryland that we also often utilize as well in terms of the dosing. We have our own dosing at Elmhurst, but it gives a nice overall schematic of it. But basically, in patients that have warfarin with a traumatic intracranial hemorrhage, you go on to give them Kcentra 2,000 units straight off, and then you can do a dose adjustment based upon the INR that they have. With DOACs, typically we want to use Kcentra. If we're going to use Kcentra, we want to use 50 units per kilogram. So we'll often give them like 2,000 units initially, and then give them an additional dose to bring them up to the 50 units per kilogram, which is basically the maximum dose of 4-factor PCC. There's a fair amount of literature on the safety of anticoagulation reversal. They basically found that there was there's several studies. This one is one recent one in Neurosurgical Review that found no statistically significant difference between 4-factor PCC and FFP and mortality and thromboembolic incidents. And then there's been several meta-analyses looking at Andexanet versus 4-factor PCC for DOAC reversal. And really the jury's still out on whether or not Andexanet is significantly more effective than 4-factor PCC. There's a lot of meta-analyses indicating that they seem to be equivalent in terms of their ability to promote hemostasis in these patients. Again, there's really a lack of clear efficacy in terms of antiplatelet reversal in patients with TBI that are on antiplatelet therapy, particularly monotherapy. That goes for both DDAVP and platelet transfusion. There's really, we all know about the patch trial, which showed that in spontaneous ICH that platelet transfusions were associated with more adverse events and no increased efficacy in preventing hemorrhage expansion. A similar trial hasn't been done in a randomized trial, hasn't been done in traumatic brain injury, but there's a preponderance of evidence to indicate that platelet transfusion, by and large, at least doesn't seem to be harmful as much potentially as it is in spontaneous ICH, but there isn't a great evidence that it's more effective than standard care, which is not transfusing platelets. Similarly for DDAVP, there's little evidence to suggest that it is actually that helpful. That being said, at Elmhurst, we still do give DDAVP to most patients if we want to reverse their antiplatelet therapy, partly because there's often very little downside to giving it. And we do give platelet transfusions, but particularly only in those patients that either need neurosurgical intervention or have thrombocytopenia. There is a fair amount of evidence that thrombocytopenia in particular, more so than antiplatelet dysfunction, it is associated with both hemorrhage progression and mortality. So if you see like here, a platelet level of less than 150 is an independent risk factor for hemorrhage progression, severe TBI, and then a platelet level of both less than 175 and 100 is also a predictor for mortality. There is evidence that DDAVP does improve bleeding time and increases platelet aggregation in both humans and animals. But again, in terms of using it in humans for antiplatelet reversal, very little evidence that either DDAVP or platelet transfusions improve survival or decreases hemorrhage expansion. And we're actually looking at this in our patient population at Elmhurst as well, including looking at TEG and platelet mapping results in these patients. And our preliminary results seem to indicate that DDAVP and platelet transfusion was not associated with decreased risk for hemorrhage expansion as well. This has been looked at in some meta-analysis. This is a role of platelet transfusions after intracranial hemorrhage, traumatic intracranial hemorrhage, and basically it actually favored standard of care, which was not transfusing these patients in terms of less mortality. That's past trial results. And so in terms of resumption of anticoagulation and antiplatelet medications, again, it's really a balance of the severity of the TBI, the bleeding status, and the need for anticoagulation and antiplatelet medication. There was a recent study that had 171 patients with mechanical heart valves with ICH, not traumatic. Some included some traumatic ICHs, but also spontaneous ICH. And they found that withholding anticoagulation for at least 7 days is likely safe in these patients. Another study was looking at specifically at TBI and patients with atrial fibrillation on DOACs, and they restarted the DOACs almost a month out from the TBI. They had one recurrent hemorrhage and one patient with an embolic stroke. We've looked at this at Elmhurst and we've submitted this for publication, but this is a case series of patients that came in that were either on pre-injury anticoagulation or that developed a need for anticoagulation while they were in the hospital. And we tend to favor, or at least I do, tend to favor using apixaban because of its purported, improved safety profile, at least with spontaneous ICH in patients that are anticoagulated with it. And so extrapolating to the TBI population, I've started using this when I needed long-term anticoagulation, and we have not had any patients that have had any new or worsening hemorrhage after starting them on apixaban post-TBI, nor any unplanned neurosurgical intervention. And we've started them on about a mean time of about a week after their TBI. So in the last couple minutes, just touch a little bit on subacute and chronic subdural hematoma, because this is obviously one of the main disease entities we see in the elderly population. As Dr. Arthur had mentioned, it's a pretty significant number of cases per 100,000 persons, 13 to 17. It's increasing in incidence, both because of aging population and those patients tend to be on anticoagulation and antiplatelet medications. There's a high mortality for patients with chronic subdural hematomas, up to almost a third within a year of hospitalization. And it really is now understood to be an inflammatory process that develops within the dura itself, resulting in the development of membranes with neoangiogenesis supplied largely by the middle meningeal artery. If you look at medical therapy, one of the things we were even did when I was a resident was using steroids for medical therapy for chronic subdural hematomas. Peter Hutchinson from the UK, from Cambridge, did a large multi-center randomized controlled trial with almost 1,000 patients, placebo-controlled trial. And they found that while dexamethasone did reduce the need for surgery for recurrence, these patients had more serious adverse events and had less favorable outcome to patients that were just treated with placebo. So by and large, I've stopped using steroids unless it's the only remaining option in these patients. I haven't used steroids in quite some time for patients with chronic subdural hematoma. If you look at the surgical management of chronic subdural hematoma before middle meningeal artery embolization, we were basically have an option of twistal craniostomy. So that would be what a SEPS is, subdural evacuating port system, essentially. Burr holes either at the bedside or in the OR, and then craniotomy. And again, as Dr. Arthur had mentioned, there's high recurrence rates for any of these procedures. But middle meningeal artery embolization has really kind of revolutionized this and seemingly is reducing the risk of recurrence in these patients, and in select patients may be used as a primary treatment as well, with avoiding the need for any surgical intervention. So if you look at our paradigm at Elmhurst, this blue line here is SEPS, so twistal craniostomies, and then with the start of our neuroendovascular program at Elmhurst in 2020, our neuroendovascular team has started doing middle meningeal artery embolizations pretty routinely for patients with subacute and chronic subdurals. So a lot of these are being done by Haasem and Tomo. And you can see there's been a dramatic increase both in our use of minimally invasive methods to evacuate chronic subdurals, as well as middle meningeal artery embolization, either as a primary or an adjunctive treatment. So typically what we do is patients with smaller asymptomatic but growing chronic subdurals or minimally symptomatic chronic subdurals that are basically too small for evacuation, we'll treat these medically with atorvastatin. There is a study from Asia looking at this. It's not the most robust study, but a lot of people are on statins anyway, and there's low dose statins have a pretty favorable risk profile, so we'll often use that. And then we will often treat these patients with primary MMA embolization. Patients with a moderate or large chronic subdural with mass effect and minimal membranes will often attempt a minimally invasive evacuation first with adjunctive MMA embolization. This allows us to avoid general anesthesia in these patients. There seems to be less pneumocephalus, which is probably an underappreciated issue that relates to increased ICU and length of hospital stay in patients that get burr holes or craniotomy. Theoretically, there should be less recurrence with the use of adjunctive MMA embolization. And then in patients that either fail a bedside SEPS or have a moderate or large chronic subdural with mass effect with significant membranes where it wouldn't be appropriate to do a minimally invasive evacuation, then those are patients we'll take to the OR for burr holes or craniotomy. And then again, we'll often follow that up with middle meningeal artery embolization, unless of course we've taken the MMA during the surgery. So last slide, in terms of key points that I just wanted to reiterate. First is that TBI is really now a disease of the elderly population. It is going to start to account for the majority of TBI cases in the coming years, and it's already up to about 40–45%. It also is a high risk group for both mortality and progression of their intracranial hemorrhage, and they tend to have all things otherwise equal, they tend to have a higher severity of their TBI. Most of these are low energy injuries, such as falls. And importantly, the energy transfer doesn't seem to be predictive of the TBI severity. So these patients can have a very severe TBI with a very low energy injury. Elderly TBI with a positive head CT should be treated at trauma centers. It's evidence that these patients do better at trauma centers. And again, we should really stop talking so much about age, but we should really be talking about frailty, and that is more predictive than age in predicting outcome in TBI. That said, many operative elderly patients with TBI do well, particularly those with mild TBI. And then reversal and resumption of anticoagulation antiplatelet therapy is a balancing act. And really, the jury's out on whether it's necessary to reverse antiplatelet therapy unless you're operating or doing a procedure on the patient. chronic subdural hematoma is going to become the most common surgical procedure we deal with. And MMA embolization is a promising novel therapy that is really helping shift the treatment paradigm for these patients and improving their outcomes, it seems. Thank you. Any questions? All right.
Thanks a lot, Zach. That was an awesome summary. There's a lot of excitement with MMA Embo with the trials coming out. They were presented maybe 6 months ago and should be coming out in journals kind of imminently.
Yeah. Basically, I mean, there's almost not a patient that has a subacute or chronic subdural that I don't get you guys at least involved in to get opinion. Because I mean, there's obviously still recurrences, but we're looking at our own data here at Elmhurst, but it's nowhere near the rate that we used to see. Just offhand, since you guys have been doing MMA embolizations here, I don't think I've taken a patient back to the OR for recurrence.
Yeah.
I would have to look at the numbers, but I can't think of one.
Are you using atorvastatin for everybody?
Pretty much, but 20 milligrams. So it's not the dose you would give after a stroke or something.
But not in acute subdurals, or only if there's a chronic component?
No, only if it's developing into a subacute and chronic subdural and it's not resolving. So if somebody comes in with an acute subdural, we're going to follow them until it basically resolves completely, not necessarily as an inpatient. As an inpatient, I like to see it start to chronify and then see whether it's getting bigger or smaller as they're an inpatient. Because if it's obviously getting bigger, I'm going to keep them usually as an inpatient to potentially address it while it's a subacute subdural before it gets too big. If it's chronifying and getting smaller, then I'll follow it as an outpatient. But I'll start it if it's like persisting for after a couple of weeks and hasn't gone away.
Yeah.
Zach, are there any prospective studies looking at what percentage of these acute subdurals in patients over, say, 60 turn into chronic subdurals that should be treated? And do you think that, if we, with that information, we would consider embolizing even some patients with acute subdurals?
That's a great question. So no, in terms of prospective, I mean, I'm not even sure of any great retrospective studies that have given great numbers on that. But that's something we should look at. I think.
Yeah, I think anything retrospective is going to have a denominator problem.
Yeah, so. Exactly. Off the top of my head, I would say it was also one of those hard things to do because you have to make sure you have like good capture of those patients. So like doing it in a prospective fashion is ideal because it's very, if you have somebody that's lost a follow-up, did they actually develop a chronic subdural and just went somewhere else, right? It's very hard to say. So of those patients that have continued to follow up with us, which I resolved, I would say it's probably in the range of like 10 to 15%, somewhere in that range, 10 to 20, maybe.
Well, if any of the junior residents are still on and listening, this could be a good 5-year project. To capture all of the consults we get for acute hemorrhages in the health system and track them.
And I think what you're alluding to, like you said, there is going to be a group of acute subdurals that would probably benefit from MMA embolization and preventing them. I guess the question is going to really be, can we predict which ones do or not? Or is just the risk profile of doing the MMA embolization low enough that it's worthwhile just to treat them all? Similar to like asymptomatic carotid stenosis, right? Like at a certain point, the risk of a stroke becomes high enough that you should just do a carotid endarterectomy, right? In a certain way. So we might find that that's the case, right? In acute subdurals, if there's really 15 to 20% of them are going to develop a chronic subdural, need something more invasive, Yeah, but I'm not aware of a study that's looked at that rigorously, no. But we can do it.
I think we're past 9 o'clock. Thanks everyone for staying on. It's a great topic of conversation and really relevant to our patient population. See everybody next week. Thanks, Zach.
Thanks a lot, Zach.
Thank you.